I guess we'll go ahead and get started here. Roda Midag, Minam is Rizwan Aslam. I'm from Nouvelle-Orléans, or New Orleans, Louisiana. I'd like to thank Tom and Cijo for inviting me. I'd also like them to say thank you to them for having me follow up a world-renowned microvascular microsurgeon with my talk. So the shoes are quite big. My videos are not as interesting as Dr. Koshima's, but maybe it'll be enough to interest you. So we're going to talk actually a little bit about endocrine surgery. My practice in particular includes head and neck surgical micro-reconstruction as well as surgical ablation of oncologic tumors. So I have quite a diverse interest when it comes to the head and neck. Kind of an interesting that we did utilizing the robot is take a different approach to the thyroid rather than go through a standard transcervical approach. This is not anything new. This was popularized in Asia, where having an incision on the neck was considered to be not fashionably suitable and actually socially difficult for females. So they developed a transaxillary approach, but we said, why not put an incision behind the ear and use it as a facelift approach, and we've combined it in succinct with a contralateral facelift as well. We'll also talk quickly about transoral surgery and transoral removal of the thyroid gland. I'm going to try to keep this on pace because I know we have some time to make up. But in addition, I know there's some students and residents in the room. Are you guys, there's some junior faculty and students, and I think it's an exciting time to be a part of medicine despite all the numbers game and the cost and so forth. It kind of makes us worried about what's becoming a medicine, but after sitting through lectures and conferences like this, you can see that the future is very bright. And one thing always to keep in mind is that after you distill away all the fancy robots, all the fancy toys, it's about you and the patient. So always remember that, and it makes the rest of it, when you start looking at different techniques and differentiating yourself from the next guy or getting involved in cost leadership in your hospital, always remember the fundamental practice of medicine is you and the patient. This is Dr. DeBakey. Many of you may be familiar with him. He popularized the first artificial heart pump. This is my family. We celebrate Mardi Gras in New Orleans, Louisiana. I know you guys in February had a very similar carnival here. This is my children. They have some beads. In a very lawful way, they got those. I have nothing to disclose. Robotic thyroidectomy, parathyroidectomy provides an adequate stereoptic three-dimensional view of the thyroid gland. It eliminates a lot of the problems that many of you have heard with utilization of robot in the prior talks. This is a kind of a paper that we did a couple years ago where we looked at single remote access through a retroauricular incision. At our institution, myself and one of my colleagues, who's an endocrine surgeon, Dr. Candile. It was a prospective study. We collected our data from 2012 to 2015. What patients met criteria for robotic thyroidectomy: enlarging benign, suspicious, or malignant thyroid nodules. They had to be less than 4 centimeters in size, or a single localized parathyroid adenoma. We've actually expanded this to 4-gland exploration. You can get excellent visualization and go to the contralateral side and visualize the entire thyroid bed on the other side as well. We don't typically do this case for patients who've had prior neck surgery, substernal goiters, advanced Graves' disease, advanced thyroid cancer, or cervical or distant Mets. We have performed neck dissection through the axillary approach, which is a beautiful technique as well. So we looked at different things like patient demographics and so forth. Obviously, many of you know the most important thing we worry about is the function of the recurrent laryngeal nerve during thyroidectomy. So it's very critical to preoperatively assess these patients as well as intraoperatively and then postoperatively. And that's one of the things we use as an assessment protocol during our study. The procedure, I'm going to get right to the video here for sake of time. Here you can see we're designing a retroauricular incision. This was designed in conjunction with one of our facial plastic surgeons here. So we're injecting lidocaine deep to the skin. We always perform an intraoperative ultrasound just to assess the thyroid gland and make sure that our technique in our plan is suitable to prior surgery. Here you can see designing a retroauricular incision. We've elevated a tunnel above this is a supraplatysma tunnel. Like a lot of people would go deep to the platysma, we go above the platysma, and I'll tell you about that why in a second. The robot's been docked. Here you can see that there is a Chung retractor. This is developed in Korea. Here's docking of the robot. And you can see the excellent visualization you have here with the robot. In fact, you hear that we're grasping the superior pole, we're ligating the superior pole vasculature. In blunt dissection, and this is actually, so this is the patient's head, this is the feet, here's the trachea, and this is the right thyroid lobe. You can see now the trachea is coming into view, and we're slowly dissecting the thyroid gland. Here's a parathyroid gland, so if you're doing a parathyroid adenoma, it's readily visualized. And here we're stimulating the recurrent laryngeal nerve in the field. And next we'll just simply take the thyroid gland, using harmonic technology. Ligation of the inferior pole is completed. The gland is then removed, and then we go to the contralateral side where we do another facelift incision. And in this particular patient, we performed a neck lift, and then plication of the plication sutures were placed, and neck tightening was done. So we had a total of 38 patients, all were females, average BMI of 26.9. The size of the thyroid nodule, a mean of 2 centimeters. These are a sample of the procedures that we performed. Blood loss was minimal. We had seroma, hyposthesia, transient hoarseness in 2 patients. Overall, all patients did really well. There was no evidence of recurrent laryngeal nerve palsy in a long-term setting. So we were able to successfully complete this. You can see the preoperative and postoperative incisions. They're well hidden, so no thyroidectomy incision on the neck. Here you can see they're very humble results, but overall the patient was really happy with her postoperative outcome. So what about doing transoral thyroidectomy? We can look at an evolution of taking the thyroid gland out through the mouth. Now many people would say that sounds totally crazy. Why would you take the thyroid gland out through the mouth and risk infection into the neck? And I guess the question is, it sounds crazy, but why not? There's always opportunity to expand our horizons. We're in the neck anyway. We know that patients could do well with antibiotics. So this is something that also been done in Thailand initially using endoscopic approach, but since the last time I was here, we're actually going to perform our first case totally robotic and endoscopically in the next few months. So initially we took a look and said, you know what, we're already using the robot to remove cancers from the hypopharynx or the oropharynx of the patient. And this is a particular case here where I had a gentleman who had a tumor located in the hypopharynx, which is behind the larynx, inaccessible through traditional approaches unless you split the mandible, which I'll show you a picture of here. You can see this is a typical mandibulotomy, which I'll use to access a tumor that may be difficult to gain access through the mouth. So we need to make a mandibulotomy. Sorry, let's see what you guys are looking at here. Here you can see the mandibulotomy, and this is the old way of doing it. So with the robot, we're allowed a 3-dimensional view. We dock the robot, we get inside the patient's oral cavity, and the exposure is incredible. I'm just going to go back one slide to let you know where we're operating at. We're operating at this level, okay? So I had this patient, he did not want any tracheotomy, he did not want his mandible split, he didn't want anything else except for me to use the robot here. And I'm going to show you here a quick demonstration of this. This is kind of a nasty looking tumor that's very low. You would not see this if you opened up the patient's mouth. You would have to use a robotic technique or a fiber optic examination to really see that tumor. So we actually have commercially available the OmniGuide laser, which I have grasped here at the robot, which makes a nice, beautiful mucosal cut. The thermal footprint from this is much smaller than using a cautery or a typical bovie. Here again, so I actually take this incision all the way down to the prevertebral fascia. And this will actually, here we're looking, so just for orientation, this is the endotracheal tube, so this is anterior, this is posterior, and if you went down here, you would go into the cervical esophagus. So again, you can see I'm utilizing a laser. Towards the end of the case, I do switch over to a bovie. And again, this is where the cervical esophagus begins. So this is almost an impossible area to operate on with any other technique besides robotic technique. So this patient essentially was spared mandibulotomy and mandibular resection to get access to the tumor here. And here you can see this is what the surgical field looks like afterwards. The tumor is completely eradicated from this area, endotracheal tube. Now you can see there is a significant amount of thermal injury to the endotracheal tube, and this is a laser safety tube, but you can still see that there's a lot of thermal heat here, so you have to be careful when it comes to oxygen and so forth. So what's next? Benign, malignant tumors, transoral thyroidectomy. Again, for sake of time, we're gonna push through some of these slides. Building upon doing a thyroidectomy from a retroauricular incision, we took a look and we said, you know what, can we do this through the mouth? So the advantages of going through the mouth include there's no surgical incision, quick recovery time. You get endoscopic evaluation of the thyroid bed. Some of the disadvantages could be that there may end up being infections, subcutaneous emphysema. The mental nerve, which is located lateral to the lateral incisors, could be injured during this procedure, and the patient could have a numb chin or numb lip. Not very nice when you try to go eat or drink. Facial nerve paralysis, the marginal mandibular nerve actually enters right about 1 centimeter lateral here. So those are kind of things that we had to decide upon where we're going to take this risk initially. The other important thing was to learn the anatomy from inside out. This is a cadaveric study that we did at our institution where you can see the cadaver's been injected. You can see these are large vessels here that feed the thyroid gland. So it's important to understand where those vessels come at when you're coming from the inside out. So we studied this in the lab. The approach would involve going through the gingival-labial sulcus. Here's your exposure. So we have this corridor that we create over the chin. Here's a short video that I did in a cadaver, just demonstrating the mental nerves here. Okay, so this is actually the anterior aspect here, the mentum. And we're going to create a tunnel. Here's the strap muscles, the left side, the right side. And we're able to elevate a tunnel here, which is actually pretty nice exposure. So traditionally, the way you do a thyroidectomy is through the front and come through. Now we're coming from the top. So it's a little different when you think about the anatomy. Slowly dissecting out the superior pole. And we're able to identify the recurrent laryngeal nerve at the base here. So how to do this, there's a couple different techniques using trocars with the robotic arms. That looks like a lot of instrumentation in somebody's small area here, and it is. So that's why the retraction is important. We have to be very careful with the mental nerves. Here's kind of the setup with the robot. This is actually with an endoscopic approach. But looking at some of the data and the studies that have been done regarding this, there's a study, initial study that was performed, 8 patients, all resumed normal PO intake after 1 day. Some did have 6 months of sensory changes within the chin. There was 1 recurrent laryngeal nerve palsy. There was no infection with antibiotics after 3 days. A second study that was done that showed 3 mental nerve paresthesias was improved by 4 weeks. Again, that's kind of the main thing that we worry about here, and no infection. So in conclusion, transoral thyroidectomy in select patients may be a great option for a lot of people. I mean, it's even better than having a skin in the back, incision in the back of your neck. Where do we go from here? There has been some talk of transtracheal thyroidectomy. I have no experience with that, but maybe it's something that will come into fruition later. Developing better instrumentation. We are working with our neurosurgeons at our institution to do spine surgery with the robot. And finally, Da Vinci does have the single-site robot as well as another commercially available robot in the US that can allow for that. If anybody would like to come and visit us in New Orleans or spend time or do research with us, we're always welcome to having students, residents, fellows come and spend some time in our lab. Thank you very much.